Hi guys. Some of you, I have seen you all day. You have to be sick of me by now. Oh, how are we doing? Best we can.
Good.
So
How are you?
tired. Surviving.
I am done with today. I'm hoping we can get through this with this little pain as possible because yeah, I'm over it today. I'm like, I need to go to bed. All right, so I try to see if anybody else is going to pop in. We got a bunch here tonight. I feel bad because this Jeopardy is not as big as the one we had last week, and it's not as big as the one we have next week. Next week is my favorite because there's actually like, it's cute. It's cute. So we'll do it the same way we did last week, where we'll go through, answer the question, and then we're just going to expound on whatever we talked about, ask any questions that's not clear, and kind of just go from there. Dot those I's, cross those T's. So I guess with that, we can get it started. Let me just move some stuff around with browser tabs and we will be ready to go. What do I want to do? I want to do this and I want to share my screen. See, I only left my desk like an hour today, so all right, we can see our Jeopardy board. We are good to go. All right, who is kicking it off for us tonight?
Valvular disorders for 200.
All righty. So these disorders are caused by hardening and thickening of valve leaves.
Is this like asking about stenosis and
So this would be a valvular stenosis.
valvular stenosis?
Okay. Remember, with the valves, we primarily talk about mitral and aortic because the left-sided heart problems cause the most damage. Any four of the valves could have this problem, but the mitral and the aortic cause the biggest issues. So
Is this where we can have that prolapse too? Doesn't the valve like prolapse in, or it does something where it doesn't completely?
so that's a different valvular disorder.
Isn't this the one where it gets like super thick? The left side of the heart gets like very muscular and strong.
It can.
Too much.
No, it definitely can. With regurg and stenosis probably more because the leaflets are so hard that they don't close all the way and they don't open all the way. So when they close, blood can get through. When they open, not enough blood can get through. So we're going to have decreased cardiac output, insufficient throughout the whole body. And then depending on which valve has the stenosis, we would have the hypertrophy. And remember, with the valves, it's everything behind that we're going to see those issues first. Okay, so aortic valve, well, let's see what the next question is before I go on and on and on. So, okay. What is next?
Inflammatory disorders 100.
Hey, this is the only cause of rheumatic endocarditis.
Would it be strep throat or streptococcal or whatever?
Yep. What's the name of that bacteria?
It's like group A. It's there somewhere. Group A something.
Group A, beta hemolytic strep.
That is it.
Yeah.
Group A beta hemolytic strep. I just wanted to see if anybody could remember. Streptococcus totally works, but strep throat is caused by that long name. So just wanted to see if anybody remembered or actually listens when I talk. All right, high five. What do we got next?
Heart failure 100.
Cough, crackles, DOE, restlessness.
Left-sided heart failure.
What about left-sided heart failure? What are these?
Pulmonary.
What was that?
Aren't those pulmonary fluid symptoms.
Yep.
You have fluid in your lungs.
Yep. So these are symptoms of left-sided heart failure. Wet, pulmonary congestion. Everything is going to go backwards because that left side of the heart is failing. What's behind the left side of the heart? The lungs. So we have the shortness of breath, the dyspnea on exertion, not being able to breathe, feeling like you're drowning. Awesome. Oops, I didn't hit the right button. Okay. What's next?
Let's do diagnostics and therapeutic procedures 100.
This lab is used to help diagnose a MI.
Troponin.
That is correct. So remember with the labs, we do have a bunch that we would do. We do the troponins, we can do a CKMB and a CK, we'll check electrolytes, but that troponin is cardiac specific. It is telling us, yes, our cardiac muscle has been damaged from ischemia. So the other ones have other purposes. The troponin is cardiac specific. So with this, when do we see the peak? Or when do we see it start? When would it be in the blood?
2 to 3 hours.
2 to 3 hours.
2 to 3 hours. It's going to be at its peak when?
24 hours.
24.
And how long is it going to be in the blood?
7 to
7 to 10 days. So, yeah, we'll definitely do the other ones, but this one is cardiac specific. So it gives us more of a picture. The other one could be other muscle damage. This one is only the heart. All right.
What about diagnostic and therapeutic procedures for 500?
Ooh, heavy hitter. These are the 3 types of percutaneous coronary interventions.
Or is this like placing a stent in like placing a stent, doing a bypass? No, a cabbage? No.
No, that'll be open heart surgery. So this is like a
Okay.
little bit way less invasive than that, but still is life-saving.
Is this like the transluminary one where they deflate it, inflate it, and then that cage will?
Yep. So they can do the transluminal coronary angioplasty. So they go in, they smush the plaques. Then we can also do the stenting, or they could do like a removal of okiguk from an
Oh,
artery.
when they go in and scrape it out.
Mhm.
Okay.
So usually, I can't say usually, but oftentimes when they do the angioplasty, where they open it up and smush it, they'll put the stent in at the same time. It reinforces the artery and allows it to stay open and prevents it from closing back up. Plus those plaques on those arteries will weaken those arterial walls over time too. So that will kind of reinforce it and hopefully potentially prevent rupture from happening. So, okay. That was a doozy for the 500.
Yeah.
Okay.
Let's do heart failure for 200.
Sounds good. Pink frothy sputum is an indication of what complication?
The left-sided heart failure.
Pink frothy sputum.
Is it pulmonary congestion?
Pulmonary is
Edema.
edema. Yep. Pink frothy sputum, we have to think pulmonary edema. So we can have frothy sputum with other things, but when that pink is thrown in there, pink and pulmonary, I don't know. That's one way to kind of remember it. So has to do with the ruptured papillary response, usually after an MI, that this can commonly happen. Remember, it can come on suddenly. We call that flash edema, where just fills with fluid and causes a whole bunch of issues. We need to intubate, we need to diurese. Those are big ones.
So this is not always caused by left-sided heart failure. It can just happen.
It
Or the
could
biggest
be,
cause
yeah.
is.
So we have the pulmonary edema, which can be caused by like overload, failing of the heart, backflow of things. That flash edema that comes on rapidly is usually caused by an MI. All right.
Coronary vascular disorders, 300.
The difference between stable and unstable angina.
Well, with
Uh,
stable, the pain goes away after you rest. When you rest for a bit, the pain will go away. And then with unstable, you also get the STEMI, the ST elevation. And the pain
Potentially.
doesn't go away.
Yeah.
The
We're
pain
on
doesn't
our
go away when you rest. It's still there.
Yep. What is that chest pain? What causes the chest pain?
Isn't it
Lack
like
of oxygen.
Yep. It is a lack of oxygen, usually due to a coronary artery obstruction. We're pinched off. Got it full of gunk, and it's not letting blood and oxygen get to the vessels, and that's what causes the chest pain. So with exercise, we can, if we stop it and we rest, it allows for oxygen to get everywhere else and can help. So that's why it's stable. And then, or if we give nitro, helps open things up, relieves the chest pain. And then with unstable, it doesn't matter. So that is, it's like a precursor to an MI. We're on our way there. Okay.
Do inflammatory disorders for 400.
So identify a key difference for each cardiac, inflammatory, or infection. So we had 4 big diseases that we talked about. All had some similar presentations, but each one had one key difference that separated it from everybody else.
So myocarditis was like cardiomegaly. It's an enlarged heart. And
Yep.
infective endocarditis is that splinter hemorrhage. And the other endocarditis, the rheumatic, is, I don't know, like a manifestation, just the rheumatic fever, like a high fever, all of that. And then the first one was the pericarditis, and that would be like it's alleviated when they're leaning forward.
Awesome. You killed that.
I just
100%.
literally read that. I just read it like
I'm
5
like,
minutes
damn,
ago.
I was lost.
Yep. So pericarditis, it's like a hot iron on the chest, but when they lean forward, it helps relieve the pain. That positional change helps relieve it, but it's inflammation of the pericardium. What is one of the major causes of pericarditis?
isn't it respiratory infection?
That is one of them. Yep. Recent respiratory infection or
An MI.
a recent MI, because that troponin is itching. So that can cause that. So with pericarditis, it's inflammatory. It's not going to be bacterial. What would your treatment modalities be? Are you thinking?
NSAIDs, right? Or it usually goes away on its own.
Yeah, some anti-inflammatories to kind of help with that. Most definitely. The rheumatic endocarditis caused by strep. So they're going to have strep, probably strep-like symptoms, sore throat, swollen glands, ickiness. They develop a rash with rheumatic fever. And then they can develop the rheumatic endocarditis in the heart. So it's caused by untreated strep. Myocarditis, we have that cardiomegaly. There will be some chest pain, that sternal, the pleural friction rub at the sternal border. But the cardiomegaly is a big one for that. Definitely painful, can be viral, bacterial, fungal, or due to systemic inflammation. And then we have the infective endocarditis, which has that splinter hemorrhages, a lot of pain, fever, most commonly caused by
Like the IV drug use.
IV drug usage. Other patients that would be at risk for developing infective endocarditis would be who?
Dental patients.
Okay. Yep.
If they have a prosthetic heart valve.
Mhm.
Um,
The
structure-
cardiac device,
Mhm.
and then the malformation, like a cardiac malformation.
Mhm. Like a hole or something in there. Yep, most definitely. So anything involved with the heart, implantable devices, copper IUDs, anything metal can attract bacteria, can lead to the infective endocarditis. And these people usually know, and that's why they treat themselves prophylactically with the antibiotics before they go to the dentist, because the mouth is dirty and nasty, and lots of bugs will travel its way down. So we try to prevent that. Central lines can cause this too. Central lines lead right into that area, so we have to be careful with those as well. Awesome. That was a tough one. That could have been a 500 question, I think.
Yeah, for sure.
I think I did it for 4 because there were 4 of them, because that's the way my mind works.
Do you mind me not being on mute?
No, not at all.
Okay.
I can't hear anything. Okay, what's next?
Valvular disorders, 500.
You guys go for the
Great,
heavy
Nina,
hitters.
500.
Okay, so identify 5 modifiable risk factors for coronary artery disease.
Smoking.
Smoking,
Smoking.
obesity.
Obesity, diet, lifestyle,
How many was that?
birth
Birth
control.
Exercise.
Diabetes or something.
Yep. We can reduce our blood sugar and lose weight and make our diabetes non-existent. Okay.
Hypertension too, is that modifiable? Yeah.
It is, most definitely. Because if we quit smoking and we exercise and we eat better, not only are we going to hopefully lose weight, but we're going to reduce the stress on the heart with the high blood pressure and potentially the diabetes. So
She says
Bonus
eat healthy while I'm eating cake.
I haven't been like grazing all day because I've had so many meetings. I have like my bag of pistachios, and then I also have some hot tamales here too, which you can't see because of my background, but whatever. But I do have my fizzy lifting drink, my raspberry lime water. So there's that. Okay, so then what are some examples of non-modifiable risk factors then? Secondary question.
Age, genetics.
Family history.
Sex.
Absolutely.
Your race.
And certain races are more predisposed to coronary artery disease than others. African Americans, Native Americans, and Hispanics especially have very, very high risks of not only coronary artery disease, but also diabetes. All right, a little secondary lesson for you guys today. Oh, we jumped up to 25. I'm excited.
Heart failure for 400.
Okay. Clinical manifestations include hypotension, muffled heart sounds, JVD, and a paradoxical pulse.
Right-sided heart failure.
Is it cardiac tamponade?
There you go. Abby Grace has got it. Cardiac tamponade. So somebody remind me, what is a paradoxical pulse?
I'll take a stab at it. I think, isn't this where your heart rate goes down as you take a breath in?
Is it your heart rate or?
Your, I can't remember, blood pressure?
Yeah, so you'll see the blood pressure, the millimeters of mercury will decrease when they inhale. So we can only diagnose this if they have, excuse me, an arterial line, some kind of invasive monitoring, because otherwise we'd have no way that that's happening. So remember, cardiac tamponade. The heart, the pericardium is full of fluid, a lot of fluid, and the heart is trying to beat, but it can't, because if the fluid is preventing it from actually doing so. So we have very low cardiac output. You can't hear anything when you listen because there's so much fluid around the heart. It's like listening to something underneath water. You hear garbledness. What was the immediate treatment for cardiac tamponade?
Is it the pericardiocentesis?
That is one treatment. Yep.
That's the one with the big needle, right?
They do use a big needle to drain that pericardial sac, 100%. There's something else that we do. The nurses can do it. We get it started.
Isn't this the only heart condition where you actually give them fluids to try?
Yes,
and...
it is. Fluid resuscitation. We want to increase that. We're going to give it, it's volume expansion. So we're going to give fluids. It's going to kind of help support the heart. And then we will be draining, well, not we, but they'll be draining the fluid off to help with that. And then we'll continue to monitor to see if it returns, and fingers crossed it does not. So, okay. High five. What is next?
Heart failure 500.
5 interventions or modifications for heart failure. So people just give one. Let's do it that way.
Could this be like the diet restriction, like sodium restriction, fluid restriction? So sodium less than 2 grams a day, and then fluid less than 2 liters a day?
Yeah. So fluid restrictions will be typically dictated by the provider. But yeah, it'll have some kind of fluid restriction, especially if they are holding on to fluid. 2 grams sodium, not 4, not 5, not 6, 2. That's the ADA recommendation. So we got low sodium, fluid restrictions. What else are we going to do or have the patient change?
Is the exercise 3 times a week?
Exercise is tolerated. Yeah.
Compliance with medications.
Oh, 100%.
Just be like decrease their alcohol intake and their caffeine intake.
Okay. So decrease alcohol, decrease what did you say?
Caffeine,
Caffeine.
caffeine intake.
Stop smoking.
No smoking, 100%.
Is it like avoid stimulant medications? Could that be one of them?
Potentially. So with heart failure, we want them to move-ish, but we have to be very careful. So we're not going to restrict activity, but we encourage energy conservation because it's going to take them a lot more to do smaller things. We need to listen to the lungs. We have to monitor our labs. And one thing, it's the most tedious task that a nurse has to keep track of.
The ins and outs.
The I's and O's. 100%. What goes in has to come out, especially because we're probably going to be diuresing them. So we really have to keep track of every drop of urine. All right. Should we finish off the heart failure since we're right there? Okay. Oops, we did that one already. Wrong one. So also known as cor pulmonale, symptoms may include JVD, dependent edema, ascites, and fatigue.
Right-sided heart failure.
You guys are very excited about this one. Yes, 100%. This is right-sided heart failure. Bonus questions. What causes right-sided heart failure?
Left-sided heart failure.
Left-sided heart failure, 100%. Anything else?
COPD or any respiratory.
Why the respiratory? Why would the lungs failing cause right-sided heart failure?
Could it be because it backs up into the left, or because it's usually left and then it just a cycle, yeah, and it goes to the right.
Circle backwards, right? Because what's behind the lungs? The right side of the heart. So it's all congestion. It's all going
Now-
backwards.
I'm a little confused. Which one is usually leads to the other one? I thought right-sided heart failure led to left-sided heart failure.
No, left will lead to right.
Leads to right? Okay.
And
I
then
don't know
with-
why that was backwards in my brain then.
I think, you know, well, I can't pretend to know what's inside your brain.
There's not,
But-
it's too jumbled. I don't know.
I know that when I think of heart failure, I think of puffy feet, water retention, and that's all right-sided heart failure. Those are the symptoms that we physically see. So with left-sided, with it being more respiratory, we don't always see it, but we can hear it and kind of get that way. It's not as in your face. And I think because the left side of the heart, when stuff goes wrong, it can be so catastrophic that we would assume left is worse than right. But right is caused by left because it's just a whole backflow.
Okay.
And then what heart problem can leads to heart failure?
What heart problem leads to heart failure?
Valvular disorders.
Thank you. Valvular disorders lead to heart failure. All right. What else do we want to talk about with heart failure? So assessment wise, we have our left and our right. Okay, left lung, right rest of the body. Okay, diagnostics. What lab monitors heart failure?
BNP.
BNP.
NP. Okay. We'll also look at other electrolytes because we're looking for like sodium depletion because of the extra fluid. Interventions we talked about, low salt diet, conserving energy, eyes and O's, daily weights, medications. What kind of medications are our patients who are on heart failure? What kind of meds are they currently on?
Lasix.
Diuretics.
Okay, so some type
Calcium
of
channel blockers.
calcium
all the
channel
meds.
blockers, blood pressure meds. We have to be careful because sometimes they have low blood pressure, but yes, DIG, anything to reduce the workload of the heart. So make sure that when you're doing your review and going over things, giving a med is an intervention. And you should never give a medication if you don't know what it does. So usually if we spend a lot of time on medications, there's a reason for it. DIG is one of those medications NCLEX loves. It has a lot of safety concerns. There are things that we look at with that, so we should be very comfortable with that. Same thing with nitro. So we give meds. Education. What education would you give to your patient having heart failure?
Could it be like call for any signs or symptoms of heart failure? Call your provider.
Okay.
Like the diet change or like restricting sodium.
Maybe teach them about the diuretic. What's going to happen if you give them furosemide?
And when should we take diuretics if we can plan best case scenario?
In the morning.
In the morning.
So then that's another thing. Some of our meds have pretty big safety concerns. So what are your safety concerns with somebody who's on a diuretic?
Get up slowly, turn slowly, just be slow.
Okay.
Their potassium, if it's potassium sparing or not.
So we can look for electrolyte issues, you know, watch to see if they're going to drop or watch to see if they go sky high, make dietary changes based on that. Okay.
Tinnitus with the furosemide.
When would we have tinnitus?
administering it too fast.
Perfect.
Well,
What
we have
does
to
a
know
diuretic make you do?
pee a lot.
Okay, so what happens if you have to go to the bathroom? What are you risk for?
Walrus.
Especially if it's dark, middle of the night, you got to go to the bathroom. So call light within reach, bed in lowest position, a light on the floor or something like that so they don't fall. Call for assistance. All that stuff is actually teaching. You guys have probably said these words in clinical, but you didn't realize you're actually teaching. So keep that in mind when we're doing anything that could change pressure or cause a fall. Anything else about heart failure?
I was just wondering if we'll need to know a lot about BNP. Do we
You
just
need to know what it is. Definitely need to know what it is. Anything over 100 means
Okay.
it's failure. And then the higher the number, the worse the failure is. And it can go down based off of diuresing and the workload of the heart, but anything over 100 means that you've begun heart failure. And I say that like this because it could be slightly above and yeah. All righty. Well, if we have no other questions on heart failure, where are we diving into next?
Inflammatory disorders 200.
Risk factors for infective endocarditis, which we kind of already did.
Oh yeah, the structural cardiac malformations and the
Isn't that
bypass.
the IV drug use in the dental patients?
Yeah. So if we have structure issues, implanted cardiac devices like pacemakers or ICDs, heart valves, IV drug use, and also immunosuppression, which I don't think we really talked about too much in class, but anybody who's immunosuppressed is at risk for infection. So, okay.
Well, I feel like that one didn't count. Inflammatory disorders 300.
So these diagnostics would be ordered to help diagnose infectious and inflammatory disorders of the heart.
Like a blood panel.
So what kind of blood tests would we do?
Their white blood cell count, it would be high.
Okay,
So
we do blood count.
CBC.
That's one
Would we
thing.
do an ABG at all?
We could, but that's going to be more respiratory versus cardiac. So if there's respiratory involvement, then definitely we would do an ABG.
Would you draw a culture?
What kind of culture?
Blood culture.
Blood cultures, 100%. Whenever we're drawing labs, the blood culture, remember, is the first thing we draw. And we draw two sets from two different places. So a set is an anaerobic and an aerobic bottle, and we get it from two different places. So two different pokes. And we need to grab those first, and then we can grab all the other blood that we need. So definitely blood cultures, that blood count, because white blood cells can tell us if there's an infection. What else would we do?
Could we do a chest x-ray to see if the heart's enlarged at all?
Mm-hmm.
What about an echocardiogram?
My favorite, the echo. When in doubt, go with the echo, right?
Oh, what about the one that you put transesophageal? Would you do that? Or is that more just to look at the valves and stuff?
You definitely could. So typically when we're doing these diagnostics, you know, the transthoracic is just on the outside. It's quicker. It doesn't require sedation. So it's a good first glance. And then if we need something more in depth, we could definitely go the TEE route.
EKG.
EKG, absolutely.
Would we look at the ESR or the CRP?
Yep, those are our inflammatory markers. So ESR is your estimated sediment rate, and your CRP is your C-reactive protein. So those tell us if there's inflammation. but they don't tell us where the inflammation is, so it's helpful, but it's not. But it would tell us then if it's more of an inflammatory process versus infectious. And then the last test that I had on here was a strep test, only because if it was a strep, it was rheumatic, we do a strep swab. Yeah, those are it. And the interesting thing is that we probably do all those tests no matter what kind of disease it is. Just looking at it to rule things out and to double check and make sure.
Coronary vascular disorders for 100.
I'm getting really bad puppy dog eyes. I can cause angina, MI, or cardiac arrest.
Acute coronary syndrome.
Coronary artery disease.
Oh.
That's where I'm going to go with that. Yep. That works. So well, I'm not actually, no, I'm going to not talk. I don't want to spoil any more questions. What's next?
Should we finish out inflammatory?
Sure. So these medications are commonly used in treatment of infectious and inflammatory diseases of the heart. So granted, depending on what kind of disease, we'll have different kind of treatments, but there was a group of them.
So antibiotics, the penicillin or the cephalosporin, maybe Tylenol if they have fever, and NSAIDs if it's inflammatory.
Okay.
Would you give amphotericin if it's a fungal infection?
Only if it is a confirmed fungal infection. So antibiotics, once we know it's an infection, we'll start antibiotics while we wait for cultures to come back. But with antifungals, we have to wait till we confirm it's fungal because it's so harsh on the body and super expensive. So we don't want to expose people to that med beforehand.
And also,
Yeah, what else?
oh, just the antiviral if it's confirmed as well, right?
Yep. One more group of meds.
Pain meds.
Pain meds. This absolutely positively can probably hurt. So all of those. So think about your considerations with those antibiotics. We're always concerned about our super infections, report diarrhea, muscle pain, anything that just doesn't feel right. Fevers, if we're giving acetaminophen, how many grams can we have in a day?
4,000.
That, nothing more than that. And that's from all sources. So that's an important safety thing. Anti-inflammatories are harsh on the mucosa and the stomach. So we want to give with food. Watch with kidney disease. It's contraindicated with kidney failure. Acetaminophen is contraindicated with liver failure. We didn't talk about that, but it is. And pain medication is a difficult one because especially if they're IV drug users, that doesn't mean that we don't treat their pain, but it can send them down a very slippery slope. So all considerations we have to take into account and have open and frank discussions with our patients. All right. Anything else about the inflammatory disorders? Since we knocked out.
Wait, what was like the max of the Tylenol? Was it 4
grams
or 4,000? Okay, I was like 4,000. Holy crap. Okay, 4 grams.
4,000 milligrams.
4,000 milligrams. Okay.
All right. Where are we going to next?
Diagnostic and therapeutic procedures for 400.
I evaluate coronary artery patency.
The left heart catheterization.
Yes, it does. A left heart cath goes into what kind of vessel?
An artery.
Artery.
Whereas a right heart cath goes into what?
A vein.
Vein.
Both can be in the femoral area or in a radial area. Doesn't matter if it's left or right heart cath, they can find a vein here, an artery here, vein here, artery there. So we're going to continue on with that conversation as we progress. So why don't we let's continue on in this category. 2 or 3?
3.
Good choice. Because now we're going to talk about
Hemodynamic monitoring. Oh,
The right-sided, the right heart catheter.
the left we always remove. The right can be left in for that intensive hemodynamic monitoring. Left will look primarily at that left side of the heart and then those coronary arteries. Right is going to look at the right side of the heart and part of that pulmonary vasculature. It can determine the pressure inside that pulmonary artery to see if we're having issues with pulmonary hypertension. No matter what, if they have a left or a right heart cath, we have restrictions over what happens afterwards. Remember that there's a difference between going in through a radial or a femoral approach. So thinking back, if I go in through the groin, what are my limitations?
They have to lay flat and you have to, is it 2 hours? And you have to apply pressure, like a pressure type of dressing to the site.
It's going to be 6 hours restricted bed rest, and then their leg will be up for 6 hours. And with the arm, they just can't sleep on it. That would be the 2 hour, and that would just be limited but not restricted.
And then
And they can't sleep on the arm. Sorry.
Nope, go ahead.
No. Then you would want to watch for hematoma around the site, the insertion site.
I'm sorry, I didn't hear you, Carrie. What was
Sorry,
that?
you would want to watch and assess for hematoma
Right. Where would a hematoma form?
right around the insertion site.
Okay, so that could happen anywhere. What complication can only happen from a femoral approach?
Is it the retroperitoneal, like the bruise on the flank area, kind of?
Right. So remember, with retroperitoneal bleeding, we have bruising. So if I'm bleeding from my wrist, that's from the insertion site. Bleeding with retroperitoneal is inside the body. We see that bright red bruising around like the flank. Hematomas can form anytime we puncture the skin, or heck, if we hit it with something hard enough, we can form a hematoma. So it's just damage there. I want to tell you the right time frame for your cardiac caths. So I'm pulling that back up. Here we go.
I'm remembering 6 hours too. I think Grace is right.
Yeah, 6 hours if we go in through the groin, and then we have 2 hours with the radial approach. And they have to lay straight. They're laying flat. Their leg has to be straight. We're going to give them a urinal or a bedpan if they need to go to the bathroom. But the head of the bed can be no more than 30 degrees. It needs to be low. And then not using that arm, not laying on it, monitoring for chest pain, watching that urine output, and making sure that we're not having any bleeding are going to be our big indications. Sorry, it's been a long day. And then I start to doubt myself. We do have them be NPO beforehand because we want them to, they get sedated for this. So here we go. Let's finish it because we already know the answer to this question too.
Echocardiogram?
It is an echocardiogram, my favorite cardiac test. So what is the difference between a TTE and a TEE?
One is invasive and one is not.
Okay, which is which?
The transesophageal goes down your throat, and then the other one is just over the heart.
Exactly right. So the TEE is the tea that you drink. That's what I always remember it. Transesophageal goes down the throat. Transthoracic is on the outside. If they have the TEE, they're going to be MPO beforehand. They receive some happy juice, a little bit of numbing. The probe goes down their throat. So afterwards, we watch for sedation, we watch for safety, make sure that they can swallow, but typically they're fine afterwards. The TTE, transthoracic echo, completely non-invasive. They have to lay flat. They're just doing the ultrasound of the heart. Remember the happy guy chilling like this in the PowerPoint, all like, yay, you know, that's all they have to do. It doesn't take hours. It's a pretty quick diagnostic, about 15 minutes, depending on, it usually takes longer to get down to the department than to have the actual thing done. But they don't need to be NPO. We can do it for whatever reason. So they'll do echoes if they want to look at the valves, if they want to look at how the heart is pumping in real time. They're going to look at that ejection fraction, which is how well the heart is pumping out to the rest of the body. And that's how we can determine what's going on with the heart failing as well. All right. Couple more left.
Do valvular disorder for 500.
Woohoo! All right. So explain the difference between mechanical and biological valves.
Biological valves come from like an animal or something, like is it a pig or a cow? I don't know if it's cow, but I know pig. And then the mechanical is a device that's a valve that's mechanically manufactured and input.
Mm-hmm. Okay.
And like the mechanical valves, you always have to take the anticoagulants for the rest of your life. While biological, it's only for like 3 or so years.
3 months.
3 months. Okay. That you have to take that.
The mechanical lasts a lifetime, while the biological only lasts 7 to 10 years.
Yep.
And with our kiddos, we would prefer biological valves due to them growing and not having to be on that lifeline anticoagulant.
I don't know if we confirmed that or not. Did we?
I just like watched the recording, and maybe I'll ask my peds, but I thought you had mentioned something about that.
I remember talking about that in class. I was like, I need to defer to the peds because I'm not actually sure. I feel like
then I'll ask them tomorrow. Why not? I will
ask message in the chat and be like, so we were talking about heart valves, and I was wondering with kids which ones they would get because we really don't know.
They're like, I don't know.
Because right, do you want
I'm just kidding. I'll ask them.
Forever, or do you want to give them multiple open heart surgeries because they don't last forever? So it really is. I truly do not know.
And this is just like a really off-topic question, but like, so my sister, she got a cow artery. So do they just like love cows and pigs for like anything? Because it's so similar.
Yes. I was gonna say, have you ever dissected a fetal pig?
Oh, we did that for A&P. We did like the balls or something.
Okay. So
we did. I remember that.
The anatomy of a pig is so similar to a human's, structure-wise and size-wise. I actually got to dissect a cow heart in my A&P class in nursing school, and that thing is like the size of your head. It is giant. So the fact that the cows are, it's very cool. I wish I could go back and do it again, like in hindsight.
It was fun.
Yeah. So the pig, they're more readily available. Size-wise, they work. Compatibility with structure. They have the leaflets like we do too, so it makes the most sense. There's another animal I think that they were doing recently too, and I can't remember what it is, but they're always looking for something. So also with
So-
biological, remember that could be a cadaver, that could be it could be a
Yeah.
house from a deceased person. And these tissue does not require lifelong immunosuppressants like a liver or a kidney would. They can transplant skin or the heart valves or ligaments without the use of anti-rejection meds.
And would the autograft be like they would take the tricuspid and then put that on the left, and then they would do like a different one for the right because they're not as concerned with the right side?
Pretty much, and it has to do with the size of the valves, and it'll fit more perfectly on the right side, I guess.
Okay,
I read.
awesome.
So with the valves, mechanical lasts forever, but they are on lifelong anticoagulants, lifelong monitoring, usually an INR, but it could be one of the other drugs. Biological, they last 7 to 10 years, but they're only on anticoagulants for 3 months. So regardless, remember, they're on anticoagulants. We're worried about bleeding, bleeding precautions, safety prevention, things that we would look at. That's never going to go away in any of your classes. So even if like we're talking about some disease and we say, oh yeah, we might treat it with an anticoagulant, you have to remember bleeding precautions. Even if we don't specifically go through all what we would do, you have to remember those. Okay. What's next? Hey, you stop that, mister.
Valvular disorders 100.
I am often caused by mitral valve prolapse.
Mitral valve regurgitation.
Regurgitation. So remember, the prolapse, instead of closing, is going to kind of go the wrong way. And then with regurgitation, it prolapses, but blood also goes back out the way that it comes. So kind of think of it as like the heart's kind of like throwing up. It's going back the way it came. So when you regurgitate, you know, you get like a bad burp, you know, you get that taste. That's regurgitation. Your heart's doing that. The blood flow is going back the way it's not supposed to. So why is regurgitation an issue?
Because it decreases cardiac output.
Simple as that. So if we have then too much blood in the atria, what's going to happen to the atria?
Hypertrophy.
Gotcha.
So yes, so with mitral valve issues, we have atrial problems, right? Because it's behind the valve. The atria is going to get bigger. Also, with mitral like regurg or stenosis, if not enough blood is getting through, remember the aorta is going to dilate. The aorta is going to be like, hey, I need blood too. I'm going to get bigger and bigger to try to like say, hey, blood, come here. Like I'm ready for you, but it never gets there. So with mitral valve issues, not only will we have the atrial enlargement and atrial dysrhythmias potentially, but the aorta way ahead of it can hypertrophy and get big too because it's overdilated. So frontwards and backwards, guys.
And wouldn't we see pulmonary hypertension possibly? Or because it's like, okay. Oh shoot, I had something on the top of my head. Oh, I do. Okay. Atrial fibrillation, I saw that it was like a symptom of decreased cardiac output, but would that more specifically be for like when the atrial has those dysrhythmias, and then like the ventricle one, the aortic one would be the VFib, or is AFib for either or?
AFib is typically only with the mitral valve. If it's
Okay,
caused
cool.
by mitral valve. So AFib could be caused by any number of reasons, so much as it is irritated that day and is just like, I don't care, and the electricity doesn't want to work right. But usually mitral valve issues could cause AFib, and ventricular problems are going to cause VFib or VTAC. because it's
Okay.
overworked and
Okay.
working too hard.
Thank you.
And it makes a lot more sense after having your EKG stuff already, right?
I have that on Friday. I'm so
Oh, you're in the
excited.
Friday group. Oh, well, it'll make more
So
sense on
excited.
Friday. No problem, Sarah. I'll
Okay.
just later. Okay. Couple more.
200.
Coronary vascular. Okay. When occluded, I am known as the widowmaker.
The left, oh, go ahead.
Got main coronary artery on the front, but I'm forgetting the name.
It's like the left anterior descending coronary artery.
Yep. That is the big baddie. This is the most commonly occluded and also the most deadly. That is like an A&P question that you won't get on a test, but it's important for you guys to kind of think about with MIs. If there's an issue going on, it's probably that guy. Okay.
Let's finish out coronary vascular disease disorder.
All right. So we're talking about MI. What are the frequently seen clinical manifestations of an MI?
Chest pain, left arm pain,
Sweating.
diaphoresis,
Teeth.
Teeth?
Your teeth hurt.
That
For
your-
women, teeth hurt.
Jaw pain.
jaw pain.
Yeah.
Gastric pain.
What about vital sign wise?
Tachycardic and hypotensive.
Okay. What about your respirations?
shortness of breath,
And they would increase.
So we'd have an elevated respiration rate. They might not be very deep, so we might not be oxygenating well, but we're going to be tachypnic. Okay. And definitely some anxiety. Are there anything else that we missed with those? Pretty much it. So let's talk about treatment for MIs. So what meds are commonly would we do, and in what instance?
aspirin,
Always aspirin, always, right? 325 for the heart health. It's a platelet aggregate, so it's going to help with that right away. So aspirin has not changed. We're definitely giving aspirin, okay?
Do nitro as long as it's not a right ventricular inferior MI, or
Okay.
yeah.
Yep. Nitro if it's not a right-sided MI.
Oxygen if they're hypoxic.
Yep.
Anticoagulants.
Yes, 100%. We need anticoagulation with heparin, platelet inhibitors,
Beta blockers.
possible pain med after things have been determined.
yeah, because the pain won't kill you, but getting a clot will. So remember I mentioned we can medicate, but we have to get those anticoagulants and antiplatelet meds on board first. That has to be our priority. And that really has changed. So is it important? Yes, but so is getting those. We don't want to increase the rate of death. So they'll also get some statins, all sorts of good stuff. Because what else with MIs? Those are all the meds pretty much.
Did we say alteplase?
We could potentially, no. Well,
I don't know when we give that one. We had a huge slide on the contraindications.
we did, and usually it's with clots.
First.
So it
Okay.
really depends on We can if the clot is big enough and there aren't other contraindications. With MIs, it gets a little difficult because we can very easily have dysrhythmias, which we wouldn't want to give it then.
Yeah.
But we do it if it's in the same area of the heart, the blockage is in the same area of the heart, and it's been less than 6 hours of the chest pain. We monitor
Awesome. Okay.
significantly for bleeding. But yeah, we can. One of the most common medications that we give for the heart was nitroglycerin, which we talked about briefly. What would be your instructions for somebody who is taking nitro?
Make sure they're laying down or sitting on a chair when they take it.
Okay, fair.
So put it under the tongue. It should, if it's tingling, it means it's working. Wait 5 minutes before taking another one. It's only good for 6 months.
Store it in a dark container, away from light.
Call 911 after your first dose.
Yes. Yeah.
Pain is not resolved.
Yes. And remember, decreasing the pain from a 10 to a 3 is great, but that pain is not gone. So they would need to call 911. They're going to take their second dose and then go from there. The pain has to be a 0. What are some of the side effects of nitroglycerin?
Headache
Headache.
and hypotension.
You can't take it with Viagra.
No erectile dysfunction meds. And remember, women take them too, so we have to be careful. We can't just assume that men are taking them. Headache is one of those things. It happens. Here's some Tylenol. Truly, that's what we tell them to do. It's not a big, bad, scary side effect. We expect it to happen. So we would just tell them, educate them on that. Remember, if you're applying ointments or patches, wear gloves because that stuff can get on you too, and it will transfer and it will give you a headache and you can fall down and go boom because your blood pressure drops.
Yeah, actually, we had a substitute for our sim, and he told us all a story about some rookie nurse that didn't wear gloves when he was putting on the gel. He went and he sat down and boom. And after the nurses made sure he was okay, they took pictures and kind of made fun of him.
So that will be a mistake you never make because now you've been told twice and you had a real life story associated with it. Yeah, that ointment absorbs pretty quickly. So, okay. What other stuff about MIs do we have questions on? We talked about like what they do with it, opening up blockages with the heart cath, the angioplasty. We talked about meds, treatments. We feel good about coronary vascular stuff.
Would the nursing priority, if like a patient comes into the emergency department and complains of chest pain, would the priority be to do the EKG?
100%.
Okay.
If they complain of chest pain, it is a heart attack until proven otherwise. So the very first thing that we do is we get that EKG. And it has to be read by a physician within 10 minutes. While you're doing that EKG and getting it set up, you can do all that other stuff, but the first thing has to be that EKG.
Awesome.
Okay. Well, then let's finish out our valvular disorders here. I think you guys will know number 4, since we kind of discussed this a little bit. So mitral problems will cause disturbances in what cardiac structure initially?
The atrium, the left atrium.
And aortic valve problems will cause disturbances in
the left ventricle.
Left ventricle.
Yep. So mitral valve problems means we're going to have atrial issues. atrial hypertrophy, atrial dysrhythmias. And then with aortic valve issues, ventricular hypertrophy or ventricular dysrhythmias, our VTAC and our VFib. So really, aortic valve issues are pretty serious because if you haven't learned yet, because you haven't had class yet, VTAC and VFib are not really compatible with life, like sustaining life, especially VFib. So we can run into that pretty frequently. So these are issues where we would want to watch cardiac output, watch our oxygenation. They're going to be very, very tired, not able to do much, safety issues. And then with valvular problems, what is it preferred that we do? I don't know if I'm wording this right.
Like a repair rather than a replacement?
Yes, it's better to repair than to replace. And again, that's not for us to ever figure out, but it's patient usually tolerates the repair better, and it's not as, it's bad. They go through a lot, but it's a valve replacement is significantly more. I'll get there eventually. All right, last question here. Pharmacological management of valvular disorders may include which classes of medications?
The Coumadin, warfarin, I'm forgetting the class.
Anticoagulant.
Anticoagulant.
Yeah. Okay.
Antiplatelets. Are you gonna use?
Afterload reducing agents and like beta blockers.
Basically our blood pressure meds.
Yeah.
Yep.
Diuretics.
Diuretics. Yep. And one more. We really only talk about one medication. It has a whole big group, but we only talk about the one.
Didge.
Oh, diuretics?
Didge.
Oh.
So remember safety concerns with digoxin, signs of digoxin toxicity, nausea, vomiting, and
The halos.
The visual disturbances, a very narrow therapeutic window. What it is, I don't remember. Hypokalemia can increase the risk of developing digoxin toxicity. So if they're on Dig, we tell them that. If they're on diuretics too, we have to monitor for toxicity, making sure that the patient knows.
Would a patient ever get sent home on Lasix and digoxin?
Yeah. We'd monitor them pretty closely. They might look at a diuretic that is not as potassium dumping to reduce the risk of Dig toxicity. And quite honestly, in real world, Dig is not used as much as NCLEX and your textbooks would make you believe. So it is one of those NCLEX meds. Dig and nitro are just meds that we have to know. There's newer, later, greater meds, but this is tried and true. We know that it does work and it's generally well tolerated, but that narrow therapeutic window does make it difficult. So let's see. I don't know if there's anything from the key concepts that we didn't really hit. I know somebody's got them out. Is there anything on there that we didn't talk about? I'm grabbing my night now. I'm clearly very organized today. Cardiac enzymes, echoes, right heart caths, left heart caths. Talked briefly about hemodynamic monitoring. I think that's one thing we didn't really go on to. Remember, CVP, we want less than 6. If our CVP is greater than 6, what does that indicate?
hypervolemia or one side of the heart failure, right?
Yep.
No, right?
Too much fluid. We got fluid overload.
Okay, cool. Awesome.
So usually it is like that. Yeah. We can get that central venous pressure monitoring through that right-sided heart cath. Monitor for bleeding, monitor for infection. We could potentially perforate with our heart caths, dissect things that we're not supposed to. Yeah. Talked about PCIs. CABG, we didn't go into a whole ton. Massive open heart surgery, redoing the vasculature with either mammary or cephalic veins. No problem, Carrie. They have to be on bypass with the traditional CABG, where the machine will pump for the heart and the lungs, but there's nothing going on within the body. Then you have your newest one that doesn't require bypass. Major open heart surgery, major. Remember with surgeries, guys, no matter what kind of surgery it is, if they are like intubated, it's a major surgery. Same post-op complications will occur with somebody who has their gallbladder removed versus open heart surgery. Granted, some may be bigger, but we watch for infection. We watch for signs of respiratory distress. We want to prevent pneumonia. We want to get them moving. That does not change, okay? Coronary artery disease, angina, tests, central catheters. Any questions about our central lines? PICC lines are probably your most common. Usually put them in the arm. We have to maintain cleanliness. When they're getting put in, it's a sterile environment where we're doing dressing changes. Everybody wears a mask. Tunneled catheters, most common are like our dialysis ports, but we can have tunneled central catheters where we could do blood draws and stuff from too. Our ports implanted underneath the skin, accessed with what kind of needle?
Huber. A Huber needle?
Yep, non-coring Huber needle. We can draw blood, we can push fluids, give meds. Long-term usage, 2 to 6 years, but they have to be surgically removed when they're done. Number one complication of central lines.
Infection.
Yep, infection, that CLABSI infection. Then we went over the valvular diseases, the disorders, procedures, meds, inflammatory, left and right heart failure, echoes. We hit it all. It doesn't seem like it, but we did. Any outstanding questions? Something that's still not clear, we're still not sure about?
Yeah,
I think what? Oh, sorry. You go first.
Go ahead.
No, you go, because you go. I want to hear what you have to say.
Oh, I just did clarification on like the different CABG, like the what is it? The alternative and the traditional one. I just get like confused because I know for the traditional you do use that cardiopulmonary machine, right?
Mm-hmm.
And then for the other one, it's like it's an off pump. I guess I just like it's not clear to me like the process. I was wondering if you could like go in depth.
Sure. So with a traditional CABG, it's open heart. They both are, but they'll be on bypass and it will stop the heart and lungs, but the machine is going to perfuse oxygenated blood everywhere, but it allows them to work. So it is a massive deal. Being on bypass for whatever reason, this is one of them, takes a major toll on the body, has a high risk of them even not coming off of it. Like the heart and lungs won't restart on their own. Off pump, they're not on bypass, but they're going to use beta blockers to slow the heart rate down so much. And then they take this weird little contraption and they stabilize the heart and they do the repairs with the heart still beating, just really slowly. Not everybody does this. It is not all surgeons are created the same. So they exist is basically what we're telling you. So with cabbages, again, we're just taking some new tubes and rerouting things and letting coronary arteries have a new life because the blockages have damaged the pre-existing ones so much. We're going to create new ways for the blood to flow to the heart.
Okay. So the procedure is similar, it's just that the way they do it is different. Like, okay, that's okay. Thank you.
They're both going to redo vasculature of those arteries. One is going to be on a machine. One is going to get drugs to slow down the heart.
Gotcha. That makes sense. Thank you.
All right, Alexandra, what was your question?
I was just gonna say, for respiratory, I feel like it was so nice because every nursing intervention would be like either administer oxygen or like raise the head of the bed. But for like cardiac, I don't know why I've always struggled with nursing interventions. Like I know like priority should be an EKG if it's chest pain, but then I remember like several times we talked about how like raising the head of the bed in that case with anything cardiac doesn't necessarily help the symptoms. And so I don't know, maybe I just need to do practice questions on like nursing interventions, but like what would you know, like for respiratory, it's either O2 or the positioning. But for cardiac, I'm just like, if it's a chest pain, you do the EKG. But everything else, I'm just like, I don't really know.
So I think what it's going to come down to is ABCs. So when we're thinking about what we're going to do, what is going to directly affect our patient and help them right there. And just because an intervention is listed as an option doesn't mean that it's the best thing or it's even relevant or going to do anything. So don't let questions psych you out. Like if it says, oh yeah, give oxygen. Well, if that doesn't make sense, then don't bite it, I guess is kind of what I'm saying. So with cardiac questions, you truly have to look at what's happening with the disease and will the intervention make sense and change their status and be the most helpful, because not everything is. Like sitting them up, like, okay, that really might not help them. Laying them down might be a better option, you know, depending on what's going on. Maybe it's pain meds or a fever reducer. So your exam is on coronary artery disease, MI, the inflammatory processes, and heart failure. So four big groups of diseases, and all do have very different things. MI, EKG, save their life, promote oxygenation, prevent cellular death, prevent clots from forming. Those are our interventions with that. Don't forget that interventions can also include teaching. So what would you want to teach patients with each of these disorders? So MIs, we need you to eat better, less alcohol, exercise, you know, that sort of thing. Heart failure, rest, diurese, don't eat all that salt, you know, that sort of thing. Also, don't get tripped up on verbiage. Assessing something, assess is not an intervention. Assess is its own different thing. So interventions are doing. I'm going to give a medication. I'm going to teach. I'm going to ambulate the patient 10 feet in the hall or whatever. So, you know, if we want to assess for signs and symptoms of heart failure as an option, well, that's not an intervention. That's its own different part of the puzzle.
So assessing any of those, assessing would be a nursing intervention. Is that what I'm getting? Okay. That would be more like
continuing to monitor something is an intervention, but assessing for something in and of itself is part of the assessment process of the nursing process. So that's verbiage. That's just, it's understanding your components there.
Yeah. Awesome. Could you throw an example out to me about like a nursing, because I get like MI and I get the inflammatory with like the heart, like those interventions, but what about like with like coronary artery disease? Like would that just be rest?
Is that like lifestyle changes since you're getting the fatty plaques and stuff, and don't smoke, don't eat fat foods?
So that would be more
like the modifiable risks.
Yeah.
Okay, awesome.
Yep, education, medications, giving a medication is an intervention. So what meds do we give with coronary artery disease?
Statin.
Usually our statins, right? We want to lower cholesterol and things like that. So that's what our interventions would be geared towards with coronary artery disease, and reduce and preventing an MI from happening. Because an MI can't happen without the coronary artery disease. So we want to prevent it from getting to that.
Okay, awesome. Thank you.
Oxygen isn't, oxygen wouldn't help here. That's true. That's a disease that's more about teaching and prevention than anything else.
Because we're wanting to prevent the MI.
Right.
And yes, okay. I'm just like, yep, okay, cool. Thank you.
So what you can do too, and this is going to sound very nerdy, but look inside your nursing handbook, your Ackley and Ladwig or whatever you use, and look up coronary artery disease, and they'll give you potential diagnoses to use. And you can look at the interventions just to kind of get an idea. So with coronary artery disease, I don't know where my book is. I might have burned it. The green tab, I'm kidding. The green tabs in the beginning list diseases. And if you look at that disease, it gives you like 5 or 6 or 10 different labels you could do a care plan on. So kind of just take a peek and look at those if you're really, really confused about what interventions would be. I guess that would be something you could do too. You don't have to memorize.
Is that the Nanda book?
Yeah.
Oh, okay. I'll have to find that. And
Yeah.
That's actually really smart though. I'll look at those nursing interventions in there. Thank you.
Mm-hmm. And then with heart failure, our goal with heart failure is to prevent it from getting worse and from them dying, because it's already failing. So we don't want it to get worse. So what are we going to do? A lot of it is going to be restricting fluid, restricting sodium, preventing all this kind of stuff, reducing weight, daily weights, things like that. So you're right. Every disease kind of has its own priority and intervention. And it can be kind of hard to figure out. Sometimes it's dietary, sometimes it's oxygen. Will we need to know signs and symptoms of electrolyte imbalances like hypokalemia? I would say always. Just be able to recognize like what you would see. Muscle weakness, lethargy, especially with like sodium. If it's really low, you run the risk of seizures. So that becomes a safety concern. So part of that stuff that you learned last semester does roll in moving forward. I won't ask a question though, like signs and symptoms of hyperkalemia would be, but there could be something that alludes to hyperkalemia. Do you recognize physical symptoms or something like that? Because with potassium, with our diuretics, that could potentially pop up. So it should be somewhere stored away, filed.
So hypokalemia is like the 7 L's, and then hypers, is it murder? So it's like muscle weakness.
I don't know why you're trying to.
I don't know. No. I remember they taught us some cool thing, and
did you have
or the body cared too much for potassium?
What did you have for essentials last semester?
I had Professor Mitchell, Bryn Mitchell.
I'm going to message her and I'm going to ask her about this murder thing because I don't really know, and she's going to laugh at me.
It's like the body is trying to ditch potassium. The body cared too much. And those are like Cushing syndrome. I don't know. Don't listen to me. It's been like a long time. But the 7 L's would be like lethargic, low T wave, low urine output. Yep.
Okay.
I don't know. Does anyone else remember that? Or am I just scarred? I guess I just scarred it in my brain. I don't know.
I remember the acronyms, but I don't remember what they stand for because I swear every semester just wipes clean. So that's good.
Okay, no, thank you. I'm glad I'm not the only one.
I had messaged her, but
Okay.
it's 4:00 by her, so I don't want to wake her up. But I will definitely find out because I want to know what they all are too, because I haven't heard that, and I like learning new things to remember things by. So.
Oh no, it's awesome. It saved me. She had these cool little mnemonics that she shared us. It was cool.
Yeah, I'm gonna have to hit her up. Okay. Anything else? All right.
I feel good.
I will post this to, if you're in my group, it's on the YouTube. If you have the other professors, they'll post it in an announcement for you guys. Otherwise, reach out if you have any questions, and I will see you later.
Good night.
Thank you so much.
Thank
Thank
you.
you.